Dr. Sabyasachi Patnaik is not there. Dr. Mithun Tulsidas, good. Dr. Shilpi, good. Dr. Birendra Prasad, no, he is not there. Anirban Mandal, Arvind Kumar Maurya, is also there. Okay, so we'll start the first paper by Dr. Neha Ahmadi, A Telltale of COVID-19 Myopic Endemic. Dr. Neha, please. Mithun, you have loaded your presentation. Good, great.
Hello, hello. When to start? You'll say? Tell me when to start. When you start the time.
Good morning.
टाइमर 5 मिनट पे करना 5 मिनट में 5 मिनट 7 मिनट
Dr. Neda, you are a ratified member of All India Ophthalmic Society? Sir, इधर देखो.
Yes.
इधर camera. Thank you. Please start. 5 minutes.
Okay, so should I start, sir? Sir, should I start?
Please.
Okay. Good morning, all of you. Myself, Dr. Neda Ahmadi, and I'll be speaking on the topic A Telltale of COVID-19 Myopic Epidemic. There is no financial interest. The development of myopia is influenced by both genetic and environmental risk factors. The usual progression of myopia in myopes between 6 to 11 years is approximately 1 diopter per year with 0.3 mm of yearly axial elongation, and in between 12 to 16 years, it is approximately half diopter per year with 0.17 mm yearly of axial elongation. The adoption of digital smart devices constitute a new form of near work wherein children spend prolonged uninterrupted period of time with closer viewing distance than the conventional books. During COVID-19 pandemic, proliferation of online classes and recreational activities has tremendously increased the digital screen time among the children. Thus, we aim to study the effect of digital screen devices on progression of myopia and evaluate the changes in the axial length with myopic shift. It was a prospective observational study of 1.5 year duration conducted between September 2020 to February 2022. All school-going children with physiological myopia between the age group of 15 to 18 years were included, and children with refractive error, amblyopia, strabismus, retinal and congenital disorders, etc. were excluded. A total of 196 children were taken up after satisfying the inclusion and exclusion criteria. Written informed consent was taken. Data was collected through structured questionnaire, and average daily time spent using different devices were quantified by self-reported estimates. A comprehensive ophthalmic examination, including uncorrected visual acuity, cycloplegic refraction, slit lamp, fundus, and axial length measurements was done, and patients were followed up after 6 months. Coming to the results and discussion, there was no significant difference in age and sex distribution among the study population. The mean age was 11 years. The most common type of devices used were of handheld types because they were more convenient, portable, handy, has application for everything, and using them for games and social media was relatively easy. The mean screen time was approximately 6 hours, which can be attributed to the digital education system and increased recreational activities during lockdown. Similarly, Mary et al. Showed that mobile exposure of more than 4 hours per day, and Hansen et al. Showed that more than 6 hours per day were risk factors associated with progression of myopia. It was found in our study that out of 196 children, 172 had progression of myopia. Among these 172 with myopic shift, it was beyond physiological limit in 127, and maximum of them had axial type of myopia. The mean screen time was 6.45 hours. The mean change in spherical equivalent was minus 0.87 diopter, and the two showed a positive correlation with R value of 0.58. Similarly, Foreman J et al. Also showed that more the duration of screen time, more will be the progression of myopia. Further, the mean change in axial length was calculated, which was 0.25 mm plus minus standard deviation. A positive correlation was found between change in axial length and change in spherical equivalent, which were consistent with the finding of Zhang X et al. In his latest study. Thus, I would like to conclude that excessive usage of digital screen time during COVID-19 pandemic has accelerated the rate of progression of myopia, with axial elongation being the major component. Thus, digital screen time can be a modifiable risk factor, reduction of which can prevent the anticipated myopic epidemic. Moreover, axial length measurements can be used to monitor the progression of myopia and determine the risk of associated pathologies. Thus, regular screening must be done at every 6 to 12 months, not only with cycloplegic refraction, but also with axial length measurements. Plus, a measure should be taken to limit the screen time to 2 hours per day. Thank you.
Thank you, Dr. Nidar. Dr. Asif, you have any question? Dr. Sir? Okay, so no, 1 minute. So,
No any rule, the computer vision syndrome, like the many of the cases is in the COVID time, there is a computer vision syndrome is very much there. Any rule you know about this? Any rule for the screen rule? Any rule? Do you know?
Yeah, ma'am. 20-20-20 rule we have
It's
to
a very
follow.
must. है ना?
Yeah.
And
Like-
most important thing is how to sit front of
Yes, ma'am.
computer.
Yes,
Huh?
ma'am. The posture, the distance at which you have to keep the devices, the intensity of the room, and we should follow the 20-20-20 rule, which states that after 20 minutes of near activity, you have to look at 20 feet distance for 20 seconds.
And the most important thing is air condition when you're using something to, like behind your chair. Okay?
Yeah, yes.
Not in front. That
Yeah,
is
the illumination from the
most
behind.
important cause of dry eye that time.
Yes,
okay? And blinking technique is there.
Blinking technique.
Blinking is very most important. 15, every mouse, when you touch the mouse, you just blink your eyes. That's a remembering point. Thank you.
Thank you, ma'am. Thank you.
Dr. Nidar, how did you come to the conclusion that the average screen time was 6 hours?
So it was a questionnaire-based study, and we asked them to quantify their screen time. Well, it was subjective-based, and they filled that form in which they quantified their screen time, that how much time.
Self-quantified, okay. So my primary question is that your whole study is based on the axial length,
Yes, sir.
but nowhere in your slide you have mentioned how you have tested the axial length,
So with
which
the-
instrument you have used.
So by EcoView Biomedics and using applanation method.
Can you show me that slide, please?
So this one, 5th point, the axial length measurements by A-scan. We used applanation method, and the machine was EcoView Biomedics.
So A-scan is not very specific of how you are actually doing it, whether you are doing laser biometry or whether you are using ultrasound is not specific over here.
So we used.
So do you think there could be a variation between laser biometry and ultrasound biometry in the axial length that you are, because that is the main structure that you are, your whole study is
Yes,
based
sir,
on the axial
There
length.
can be difference, but then we used the same machine for all the patients, and only one person had done the axial length calculation for all. So to minimize the inter-observer variation also.
That is also not mentioned here that there was a single person testing all the kids. But very nice presentation. Thank you very much.
Thank you, sir.
Okay, so Dr. B.P. Kashyap, our senior ophthalmologist, has another paper in another room, so we would like to invite him first, if others in the line don't mind. And he will be talking on incidence of spectacle change within 30 days of refraction, economic loss to the optical shop. Dr. B.P. Kashyap, please.
Hi, good morning. In the era of specialty, everybody wants to see their own retina cases and cataract cases. the people say that, oh, I am parashan with the redness and itching and voting, but then these glasses are prescribed by the optometrist, but then, if something goes wrong, the patient has to spend money and he has to go to you again and change the glasses. There is some loss. So I don't have any financial interest or any conflict. In any eye care hospital, majority of the patients come to you and they require glasses, approximately 65% of them. Once the glasses are prescribed, the patient purchases the glasses. The glass frame is up to their expectation and their liking and all that, but the patient go for your prescription or your glasses. Patient spend a good amount of money for the glasses. It could vary from 2,000 rupees to even 25,000 rupees. What is change of glasses? What I mean by that? Patients are clearly told that the new pair of glasses may take around 7 to 10 days time to adjust, and after 7 to 10 days time, few patients are unhappy. When they come back, they are sent to the optical shop again for any kind of decentration or adjustment of the frames. Sometimes the patient is still unhappy and are taken for the re-refraction, and patients feel comfortable with the newly tested power glasses. This newly prescribed glasses is considered to be change of glasses. Money spent again for the glasses is a loss. Patient had already spent money. Patient wore glasses and had discomfort. Patient spent time and money again for the new pair of glasses. It becomes a burden for them to again change the glasses for the new prescription. Our hospital policy is first assessment is done by the autorefractometer. The second assessment done by junior optometrist and confirmed by the senior optom. Then the third assessment done by the treating doctor. And the fourth assessment again is done by the optical shop for any surprise powers. We don't charge the patient if they come, if the glasses are changed within 30 days. Our hospital is not to charge it for the second time. Operation in our hospital premises do not charge, but somebody is losing money. Aim of our study was we wanted to see how many patients had to repurchase a new pair of glasses within 30 days and how can we minimize it. Our study period was from 6th of April 2021 to May 2022. Inclusion criteria was all patients requiring change of power of glasses within 30 days, and we excluded those patients who immediately had immediate post-operative patients demanding early glasses, early cataract glasses where vision improves with the glasses, and some manufacturing defect. Glass change, total number of glass made was 8,200 and total number of glasses changed was just 29. After fourth tier assessment of refractive power correction, we had to increase the power than the previous prescription in just 6 patients for the patient's comfort, had to decrease the power since the patient had a headache in 5 patients, not adjustable to progressive glasses in 2 patients, and change the power of near vision in 7 patients. Now, the percentage of change of power is very, very low. The higher power in hypermetropia and lower power in myopia should be given to take care of the accommodation and glare. Hence, increase in the power in the 6 cases are justified after a trial of less power. Change in power for the near vision is very tricky since we have to see the comfort zone of the patients depending on his profession. And the first time, where for the near vision, correction needs less power, and this factor can solve many cases. In 5 cases, the power had to be reduced. This factor needs to be taken care of. So we conclude that the change of rate of power, the change of power of the glasses is to quite an extent is acceptable range. Even then, giving less power initially, less power in first time wear for the bifocal glasses, and proper handling and transport of glasses may reduce the number of need for exchange of glasses. A proper refraction is the need of the day. Please don't leave it to the optom people only. You should confirm it. Thank you.
Thank you so much, sir. That was a very insightful presentation, which will be useful in our day-to-day practice. Dr. Asif, you have any questions?
Sir, in second and third assessment, have you used cycloplegic refraction or just dry one?
We don't do cycloplegic refraction unless and
in reassessment, sir?
Yeah. No, unless until some indications are there. Indications like the patient's having a very erratic response to the refractive corrections, like sometimes the patient accepts -1, sometimes accepts +1, something of that kind. Or if the patient is very young, requiring the cycloplegic. Young means, at the age of 5 or 6.
Okay. Thank you, sir.
Dr. Pinky?
This is the very important topic we have discussed. But this thing is very important, and finally, the ophthalmologist should also confirm this type of refraction, because the patient, when the patient wear the glasses first time, they couldn't adjust. They're not acclimatized with the glasses. And after 1 month, always I say to the patient, please you adjust. And after 30 days or 1 month, you can complain. You can because the patient first time, this is very much occur in the first time wearing the glasses. And repetition is very important. Sometimes the patient, no, मैं नहीं पहनूंगा, मेरे को बड़ा अजीब लगता है ना, और वो कंप्लेन करता है, वो पहनता भी नहीं है, फिर भी आके कंप्लेन करता है कि मुझे एडजस्ट नहीं हो पाया, ठीक है ना. तो दिस टाइप ऑफ कंप्लेन ना, तो ऑलवेज शुड कॉन्सेंट्रेट कि पेशेंट ने उसको रेगुलर पहना है कि नहीं पहना है. ये भी एक बहुत बड़ा इंपॉर्टेंट चीज़ हो जाता है.
4% is not at all a very remarkable number. Actually, in my practice for the last 44 years, we used to see patients complain of some difficulty with the spectacles. First of all, they are not at all accustomed. They don't like to have the spectacles ever before. And the second thing, the speedy error is one of the common error what we used to see. The spectacle, those makers, they have got very little idea. They used to give big frame or very small frame and others. So actually the error or the difficulty with the ophthalmologist to prescribe glasses is not much, maximum 1%. But the other 3%, I think that is from the spectacle maker as well as from patient point of view, his adaptation. And today with automated perimetry, days have really changed. It's very easy, and I'm sure and I'm confident that most of the ophthalmologists like to recheck the power what the optometrist has done very quickly, and that avoids many error. Presentation is excellent.
So I must say one thing I just want to add, and this is also with me, sir. The IPD, when the digital IPD and the manual IPD is a far different. मेरा ग्लास चेंज हुआ क्योंकि उन्होंने डिजिटल किया. जब मैनुअल किया तो दैट इज द मैनुअल इज वेरी एक्यूरेट देन द डिजिटल, आई थिंक सो. इन द प्रोग्रेसिव ग्लास आल्सो, progressive glass is very important.
Sir, I have one question. What was the primary need to do this study? Was the incidence of changing of glasses at your hospital very high?
I love it, sir. I love your question.
Why this study?
Because you know, all my immediate juniors and all that say, सर अभी भी आप चश्मा चेक करते हैं क्या? हम तो सब छोड़ दिए सर, 5 साल हो गया. This is not done, sir. Ultimately, the responsibility yours, and we must see to it that the patient is comfortable. So, just to highlight it, that if you have all these 4 tiers of refractions, something going wrong is much less. So we should follow all these. Give up. You must check it again, because ultimately, what is required from you and for the patient will be justified only if you see the patient.
Sir, with all these 4 tiers, you had 5 cases in which there was a change in power. An analysis was done of where the problem was, which step went wrong.
Probably some human error, and out of 8,200 cases, 4 cases is
That analysis, that's insignificant. Thank you very much for your nice presentation.
Thank you very much for accommodating, Satyajit. Thank you very much.
Thank you, sir. Do we have Dr. Astha Agarwal? Okay, so next we'll call Dr. Sabyasachi Patnaik, sir. He'll be speaking on role of convergence insufficiency in children complaining of headache without refractive error. Dr. Sabyasachi Patnaik.
So, good morning, respected judges. I am going to speak on a study where the role of convergence insufficiency is assessed in cases of children without refractive error. Not moving. Not moving. No financial interest. So headache is one of the most common symptoms of children seeking medical attention, and mostly during COVID period this has increased. So ophthalmologists are usually asked to evaluate children with headache if there is any refractive error present or not. Mostly the headache is because of refractive error and binocular vision and abnormalities. Convergence insufficiency is a common dysfunction of binocular vision and a major cause of headache which goes undetected. So our objective of the study was to evaluate the association between convergence insufficiency and headache in children between 5 to 16 years of age without any refractive error. This is a cross-sectional hospital-based study. Institutional ethics committee approval and informed consent were obtained. 85 children with complaints of headache without refractive error who either had come by their own or were referred from other departments, mostly pediatric department, to the Department of Ophthalmology. Age above 16 years of age, uncooperative children, strabismus, inflammatory ocular disease and trauma cases were excluded from the study. Sample size was calculated based on the formula for prevalence study, and with design effect of 10%, we get the sample size of 85. So in all cases, visual acuity was measured in each eye and refraction was done, and all the children with refractive error were excluded. Slit lamp and fundus exam was done to rule out ocular pathology. Orthoptic test mostly done for both near and far, and near point of convergence was measured by RF ruler. So convergence insufficiency is defined as near point of convergence more than 10 centimeter. So SPSS version 25 was used to analyze the data. So these are the results. So majority of the patients were females, 52.94%, and males 47%, and this difference is also significant. There was abnormal near point of convergence in 43.53% of headache patients, and it is more in aged children, that is more in the group of 13 to 16 years, 55.56%. So the association between headache and near point of convergence is found to be statistically significant by chi-square test. So there are many studies done previously with prevalence varying from 4% to 26 to 28%, but in our study it is 43.53%, and the higher magnitude of convergence insufficiency in our study may be because of very selective about inclusion of only symptomatic cases with history of headache. We excluded all other. So to conclude, all children with headache, even with normal visual acuity and normal refraction, should undergo a detailed orthoptic examination, and it should be included in the school eye health exam program. So, but the limitation of our study was its little small sample size and incomplete orthoptic examination. We recommend an analytical study with larger sample size and complete orthoptic examination for establishing the cause and effect relationship between convergence insufficiency and headache. Thank you. Thank you very much.
Thank you so much, sir. That was a very nice presentation. Sir, you have any questions? Dr. Asif? Dr. Pink?
Age criteria, sir? Age criteria that your studies?
5 to 16 years.
5 to 16, sir. The accommodative accommodation is very strong, that type of patients. And I must say that in some cases, if the patient having the asthenopia, without any refractive error, but the cycloplegic contraction of the muscles is most of that type of in that age group. So most of the time I use atropine. Atropine, for the refraction too, and for the sometimes.
For treatment.
For the treatment, atropine. Because the patient gets very relief for that kind of the treatment, I think.
Correct.
And even 1 to 2 months, if continuous, you are using this type of treatment. So this type of symptoms also slow down. And there is no any effect on the eyes. Every 6 months you can check the patients. But there is no, I see that up cases, 2 to 3 cases I have seen during my PG time, and my Asif sir also is there. And some patient we are using sir in that time now, in a PG time. And there is no any asthenopic symptoms of that. And this age group is also must say 10 to 12, 9 to 10, 2 to 3 patients I have seen.
No, the
in
purpose
exam.
of the study is to detect those children
Those children.
who
yeah.
need those type of treatment.
Okay.
Rather than sending them back, that there is no refractive error and eyes are normal.
No, no, that is very important, sir.
That is the purpose of
Ha,
the study
yeah,
actually.
yeah. Thank
Most
you,
of the time we say that everything is normal, you go and consult pediatrician for your headache.
No, the symptoms is very important and you
Yes,
can concentrate that type of symptom because the patient is very,
No, we have to assess. Before telling that everything in the eye is all right, we have to exclude that there is no accommodation excess or convergence insufficiency. After that only we can label that
you
he
can
has
use
no,
the anti-cycloplegic
No,
eye drop.
I have not gone into the treatment component of this study. This
But,
study was
apart from
basically-
this, sir?
Yes, yes, there
Yes,
are many
sir.
other.
For what the duration was that?
The first thing is the convergence exercise. That push-up, pencil push-up test
Yeah,
is the
yeah.
first and simplest thing. After that, you have to give, as you told, cycloplegic and any cycloplegic actually to relieve accommodation pattern.
Thank you.
Sir, as a part of the follow-up which you said is outside the preview of this study, how would we exactly know or come to the conclusion that headache was only because of
No, it's not.
convergence
It's
insufficiency?
very difficult to establish that. That's why I said that in my study limitations, there another study with all component of is to be required. And most of the time when we see that there is a convergence insufficiency, that we have to deal first. Then the first thing that is advised is push-up, pencil push-up test to do
So, but
for
when,
convergence exercise.
but the whole basis of your study is headache.
Yes.
So we also had to evaluate whether the headache is becoming all right or not
No, that
with,
was,
with that
for this
exercise.
For this particular study, we excluded all other causes of headache. Then we only took headache.
Yes, that is exactly all other causes of headache were
Were
excluded.
excluded from this study. Primarily, we took people primary headache without any refractive error.
By the way, may I ask you one question? You were the additional director of health services in Odisha for a lot of time, and you have done a lot of school health studies and others. What is the average percentage of crossed eyes or squint among the school going children
No,
up
that
to
is
the
a-
age of 15 years?
No, as you have
A-
asked,
Any assessment have you got?
no, I have not done that. But basic thing is, when I wanted to personally do school eye health examination and refraction in children, in the guideline it is said that one ophthalmic assistant will do 50 children examination in a day, which I found is very difficult. So that has to be changed because children's refraction takes time. And the place where they do in schools and everything, that is also not a convenient place for examination to be done. So there are many fallacies in that program. We do not know.
Manifest squint.
Sir, this discussion is outside the preview of this study, so we'll thank you very much,
Next.
sir. Thank you, sir. Do we have Dr. Astha Agarwal? Okay, so now next we'll have Dr. Mithun Tulsidas, who will be speaking on corneal topography in fellow eyes with unilateral keratoconus for detection of subclinical keratoconus. Dr. Mithun Tulsidas, please.
Respected Chair and delegates, wish you all a very good morning. I would like to thank AIO Scientific Committee for giving me this opportunity. So today I'll be discussing about one of my studies, that is a corneal tomography in fellow eyes of unilateral keratoconus for detection of subclinical keratoconus. So I have no financial interest. So studies suggest that subclinical or clinical keratoconus is found in 1 to 6% of the myopic patients undergoing refractive surgery. And as we all know, advanced keratoconus can be diagnosed with clinical and tomographic findings. However, detection of the disease in the preclinical stage is difficult. So this is a pictorial representation which shows the terminologies keratoconus suspect, form frucae and subclinical keratoconus, which often are overlapping terminologies. So as you can see in the diagram, the subclinical keratoconus actually includes both the form frucae and the keratoconus suspect. So you can see a cutoff there, which is actually the tomographic cutoff. So keratoconus suspect can be defined as those with some tomographic changes but not with any clinical findings, whereas form frucae keratoconus is basically an incomplete or distorted form where there may not be any tomographic changes, so neither tomographic changes or nor any clinical changes. So basically it is very difficult to detect a case with form frucae keratoconus. So the purpose of the study was to analyze the tomographic changes in fellow eyes of unilateral keratoconus patients by comparison with normal eyes. This was a time-bound 5-year retrospective observational study, and patients with unilateral keratoconus were diagnosed by pentacam, and normal candidates for refractive surgery were included as controls. The ethical committee approval was obtained, and the study subjects were divided basically into 3 groups. The first group had 15 advanced keratoconus eyes with unilateral keratoconus, and second group with the fellow eyes of those unilateral keratoconus patients, and the third group were normal refractive surgery candidates. And now the highlighting point is that the fellow eyes didn't follow even one criteria on the pentacam, that is even the final D value less than 1.6 from the bad value was included. Exclusion criteria included any history of ocular surgery, trauma, any pathology of significant corneal scarring, and the examinations were performed using a pentacam rotating shim flip camera. All the data from the pentacam maps, that is including topographic, elevation, topometric and bad maps, were analyzed. These are the statistical methods used. We have used a chi-square test followed by a one-way ANOVA, and an ROC curve with area under curve was used for distinguishing the parameters, and an area under curve more than 0.7 is considered as significant for diagnostic specificity and sensitivity. So 64 eyes of 49 patients were analyzed, and the keratoconus manifested mainly in males and basically in left eyes. The mean age was 26 in unilateral keratoconus group and 25 in the normal group. So these were the 5 parameters which were found to be very significant between the fellow eye and the normal group. That is the corneal thickness at the apex, the thinnest point of the cornea, the corneal volume, bad thinnest point and thinnest point displacement. This is the ROC curve, and from the ROC curve we have got these 4 parameters as the significant ones with an area under curve more than 0.7 for distinguishing subclinical keratoconus. However, as you can see, the specificity of all these parameters are very low. D value and pachymetric progression index maximum were the most characteristic indices in discriminating fellow eyes with normal eyes, similar to the studies in literature. However, this study is the first study in Indian population to identify the changes in the fellow eyes of unilateral keratoconus patients. We have a few limitations. The main limitation is the small sample size. However, it might be due to the rare incidence of true unilateral keratoconus. Further studies with larger sample size and simultaneous evaluation of corneal biomechanics and wavefront aberrations may be more useful. To conclude, bad D value and pachymetric progression index were more effective than other pentacam parameters in detecting the earliest form of subclinical keratoconus. This study also highlights the usefulness of sham film imaging and not a single parameter. However, we need a combination of different data to distinguish subclinical keratoconus. Thank you.
Thank you very much. Excellent study. Excellent study.
Thank you, sir.
Dr. Pinky, you have a question?
No, ma'am. All these patients actually mainly came for, this was basically a retrospective study. So I have screened almost 600 to 700 candidates, and I have selected only those patients with unilateral keratoconus. So they had an advanced keratoconus, not even a mildest form. So an advanced keratoconus with classic clinical and tomographic findings. However, the fellow eyes was absolutely normal based on the clinical and tomographic finding. That is why we got only 15 candidates out of screening 600 to 700, because unilateral keratoconus as such is a misnomer. People usually say it to be bilateral. Maybe the other eye can be formed through say. That's why we conducted this study, so that we can actually, we consider these as borderline cases, and how can we distinguish these borderline cases from normal cases. So we found these 2 parameters could be more significant than referring just the topographic map or the tomographic map.
11 out of 15 left eye.
Yes, sir.
Statistically very high.
We couldn't find any reason for that, sir. Even I had a literature search, but there is no significant reason why the left eye manifested more.
Otherwise, excellent study. Dr. Asif, you have a question?
Sometimes the patients come, sir, with the keratoconus, with a dry eye, foreign body sensation. One patient, a college guy's girl came to me in last 2 to 3 weeks. and repeatedly she hasn't complained of the ma'am dry eye लग रहा है बहुत itching हो रही है बहुत ज़्यादा ये I never saw this on the slate lamp but she again came to me and I have seen the one eye is corneal ectasia another eye is totally normal. Then I sent for the topography and the symptoms is very important. The patient's having a complaint, okay, isko dry eye hoga, ye hoga, de do ye. But I have never looked under the slate lamp. When I noticed that the girl having this so much complaint, please ma'am, mujhe dekh lijiye, so much patient all in the government setup. Then I saw really that girl having a problem. One eye is a corneal ectasia, another eye is very totally normal. Yes. No any difference, but the patient's symptoms is very high. So that is the most important thing कि symptoms usually if the patient having this type of symptoms कि मैम दवा भी डाल रही हूँ कुछ असर भी नहीं हो रहा है और मुझे हमेशा itching लग रही है हमेशा foreign body sensation लग रहा है तो that is the main alarming sign कि if you have to see under the slit lamp. It's a very I think I just must say.
Sir, you have a question?
So maybe in a prospective study, the sleeping posture might give a better this thing like whether the patient is lying on that side where the eye is affected first.
Yes,
As this was a retrospective study, we couldn't do that. Yeah.
Correct.
Thank you.
That is what I want you to scratch your head
Yes.
for. Thank you very much.
Thank you. Thank you.
Where are you working? Where are you working?
Very nice. Do we have Dr. Shilpi Singh? Okay, so now Dr. Shilpi Singh will be the next speaker and she'll be speaking on comparison of occlusion versus dichoptic method in treatment of amblyopia in children under the age of 8 years. More than 8 years. And Shilpi is not a ratified member of All India Ophthalmic Society. Okay, so we'll not be marking you. Okay, thank you very much. Please go ahead.
Good morning to all. Myself Dr. Shilpi Singh. I am here to present my paper on comparison of occlusion versus dichoptic method in treatment of amblyopia in children more than 8 years. I don't have any financial disclosure. The informed consent for sharing picture has been taken from parents. Amblyopia is a developmental defect of spatial visual processing that occurs in the central visual pathway of the eye. Amblyopia represents diminished vision occurring during the years of visual development, secondary to abnormal visual stimulation from one or both eye. The diminished vision is beyond the level expected from the ocular pathology present. This pathology may be stimulus deprivation, strabismus, and high refractive error. Although patching of the dominant eye is the gold standard treatment for amblyopia, but it has some limitations like prolonged treatment leading to poor compliance, patching-related distress, relationship strain, and stigma. Wearing a patch disrupts binocular fusion also. Dichoptic treatment has recently been introduced as a new method of amblyopia therapy. It works by looking through a special glasses like anaglyphic glasses with a blue and red filter. And this is the picture of anaglyphic glass and children playing a dichoptic game on smartphone. This is a picture of occlusive therapy. So an observational prospective study was conducted among 40 patients having an isometropic amblyopia. These 40 all selected 40 patients were divided into two groups, Group A and Group B. And patients of age 9 to 16 years having an isometropic amblyopia were included in the study, and patients with known cause of reduced visual acuity with nystagmus and history of previous amblyopia treatment within 1 year of involvement and having skin reaction to patch or bandage were excluded from the study. The mean age of patient was 12.5 years. All 40 patients had an isometropic amblyopia. Of these patients, 2 patients from Group A failed to follow up after first visit and 4 patients from Group A failed to follow up. So at the end of the 6-month treatment period, almost all patients of Group A who had completed full course treatment showed mean improvement of about 3 lines in visual acuity chart, whereas 93.75% patient of Group B showed mean improvement of 2 lines. Outcome of Group A is far better than Group B. No adverse effect were reported during the study. This is the table showing improvement visual acuity at month 1, 3rd and 6th months of Group A patient, and this is of Group B patient. Graphical representation of the visual improvement, yellow color showing improvement of visual acuity of patient of Group A and red color of Group B. So at the end, we can conclude that conventional treatment for amblyopia with an eye patch has a lengthy treatment duration. Wearing a patch can be distressing for the child and has negative impact on academic and social life. Therefore, they try to avoid patching. Also, sometimes patching method cause reverse amblyopia, hence require frequent follow-up. So this small prospective study has shown significant visual acuity gain in lesser time with dioptic method as compared with patching method. Dioptic method is more acceptable to school-going children. With dioptic method, improvement seen even in older children, and also did not hamper their social academic life. Thank you.
Very good study. Dr. Shilpi, why you choose the children aged above 8 years?
Sir, because mostly this age is school-going age, and mostly amblyopia is detected during this age group, and also when they start to go to school, then that's why they avoid the patching method or accept dioptic method. Easy hota उन लोग के लिए खेल. That's why I decided.
What is the purpose of doing this study? As we all know, patching is time-tested, cost-effective, and
Yes, sir.
you have mentioned gold standard method of
Yes,
amblyopia
sir.
treatment.
Yes, sir. No doubt that patching is gold standard method and effective, but during school-going age, children try to avoid it because they feel embarrassing with this method, and but they love to play game. They follow मतलब, easily acceptable as dioptic game as compared to patching method. That's why it's more effective.
Question?
Sir, you want- Dr. Pinky? Thank you very much.
Thanks.
Thank you, Dr. Shilpi. We'll move on to the next presentation. Dr. Anirban Mandal is here. Okay, so we'll go on to the last presentation for this session, which is by Dr. Arvind Kumar Maurya, and he'll be speaking on RCT on binocular polarized video games versus contact lens versus occlusion therapy in amblyopia.
नहीं, ये वीडियो नहीं है आज, दूसरे हॉल में चल रहा था.
पेन ड्राइव पे ले लीजिए प्रेजेंटेशन.
पेन ड्राइव लाइए अपना, पेन ड्राइव दे दीजिए, मैं ट्रांसफ़र कर देता हूँ. You don't have a pen drive.
पेन ड्राइव नहीं है, अरे वहां से मांग के लाइए ऑडियो विजुअल से. जल्दी 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 से लेके.
ये कनेक्टर है तो सही, इससे क्यों नहीं हो रहा कनेक्ट?
पेन ड्राइव लेके आई ना वहां पर,
फटाफट पेन
जहाँ
ड्राइव.
पर लोड कर रहा है. फर्स्ट फ्लोर पर जहाँ चाय वाला है वहाँ.
Good morning, respected judges and my dear friends. Thank you for the opportunity. So I will be speaking on randomized control trial on binocular polarized video games versus contact lens versus occlusion therapy. So as we all know that amblyopia is a neurodevelopment ocular disease manifested as monocular and binocular impairments, including vision reduction, contrast sensitivity, and even loss of stereoscopic vision. And commonest of amblyopia is refractive type of amblyopia. And the occlusion therapy, it has many disadvantages. With best corrected spectacles, there is recurrence is seen as per the literature review in 25 to 50% of the cases. So the advantages of the contact lenses, that there is insignificant peak distance of fracture area from the cornea and neutral prismatic effect upon lateral gaze, an absence of anisophoria, unlimited visual field, and minimal anisoconia in anisometropia. So now there is a new treatment modality available, that is the binocular polarized video games. So they uses the binocular polarized glasses. So same background has been given to both the eyes, but enriched foreground to the amblyopic eye, and high contrast to the amblyopic eye, and fast paced engaging components are there that keeps the child engaged and interesting. And it is based on the principle that they can strengthen a broad range of visual tasks in adults with normal vision, including light sensitivity, contrast sensitivity, visual crowding, and visual attention. So this was the world's first registered clinical trial. 65 patients in each arm, age 6 to 12 years, minus 12 diopter to plus 3 diopter of the refractive error were included, and visual acuity difference between two eyes were at least 0.2 logmar. No misalignment or other ocular disease, and follow-up was done at 0, 4 weeks, and 8 weeks. And we did the Titmus fly stereo test and contrast sensitivity using the Pelly-Robson contrast sensitivity chart. So these are the different components of the Occlutab. We don't go into the detail because of the time constraint. So we come to the results now. So 99 were males and 96 females. Average age was 6.37 plus minus 2.06 years. 68% were myopic and 31% were hypermetropes. So at the baseline, the contrast sensitivity was 1.49 in the Occlupad group, 1.324 in the occlusion group, and 1.57 in the contact lens group. The best corrected visual acuity was 0.44 in the Occlupad group, and 0.384 in the occlusion group, and 0.416 in the contact lens group. And the stereo acuity was 71.65 in the Occlupad group, 64.85 in the occlusion, and 67.35 in the contact lens group. So at the 8-week follow-up, the contrast sensitivity increased to 2.24 with significant p-value of 0.05 in the Occlutab group, and 2.124, so increase in the contact lens group also, but there was no significant p-value difference as compared to the control arm. And the best corrected visual acuity also improved better in the Occlutab group as compared to the occlusion group. And stereo acuity again, it also increased as compared to the baseline, and it was better with a significant p-value of 0.05 as compared to the control arm. So in the conclusion, treating amblyopia is an enigma, and most of the management modalities require patching, and the LASIK procedures had shown good results but are associated with keratosis, and that it's an irreversible procedure. So binocular polarized Occlutab requires very less time. It requires only 30 minutes per day and 2 days per week, and it goes on for 8 weeks, and the vision remains stable for 1 year. And the main advantage that it keeps the children keen and engaged without occlusion because there are video games. Thank you so very much for giving me the opportunity.
Thank you so much, sir, for that wonderful presentation. It was excellent. So you have done, sir, literature comparison. Other studies have already been done on this. So have you made a comparison with your study to theirs?
Yeah. So it's as we compare the pinhole examination, the visual crowding method, and the contrast sensitivity and the stereo acuity, but this age group 6 to 12 has not been considered in the previous studies.
So that is why you said this is the first time that is.
Yeah, it is the first type of such study all over the worldwide literature, because there is Kelly et al. Study, and then the Dr. Lee et al. They have done the study. So this age group they haven't included.
Wonderful.
Thank you so very much. Yeah, sir.
Sir, what is the duration of treatment for diagnostic therapy?
8 weeks.
8 weeks.
Yeah.
After that?
After that, it remains stable.
Oh.
The previous literature they have done up
You
to
have mentioned it is stable for 1 year.
yeah, because follow-up is still going on. So it's 1 year is stable. It's only for 30 minutes, sir. The child has to play, means binocularity is there. They need to wear this polarized glasses. So there is no need of occlusion is there. What we are doing is the high contrast is being exposed to the amblyopic eye.
Yeah.
And the background is same. We are working on the widescreen method. But the foreground is better and it is enriched for the amblyopic eye. And it is decreased or reduced in the non-amblyopic eye. Yeah.
This is named dioptic therapy.
Yeah.
Because simultaneous but different stimulus is given to both eyes.
Yeah. Because the cortical, the binocular neurons in the V1 area are there. So they are excited. In the animal study, it came to know that the GABA adrenergic, that stimulation can be reversed in the animal models. So it can be in the humans also.
That is studied by Dr. Santhan Gopal also.
Yeah. Orthoptech, we are also working on that.
Orthoptech.
Yeah, that clinical trial is still going on.
Outcome is the outcome, total outcome.
Yeah, so better visual acuity, better contrast sensitivity, and better stereo acuity after the this Occlutab group.
Sir, have you seen the change of reduction of power? Yeah, visual acuity is increased.
No. In power, the spherical equivalent was same.
Oh.
Yeah, there was no.
But visual acuity is 612 to 69 or 66.
Yeah, that improved a lot. Means 0.44 to 0.2 in this Occlutab group.
Power remains same.
Yeah, power remained the same.
All are school-going children?
Yeah, all are school-going children. Because we use contact lenses also, no? So we cannot include means 3 or 4 year age group because they can't handle that contact lens.
How much is the compliance in the treatment?
The sample size was 80, so finally 65 came into the inclusion group.
For dioptic therapy, you train the parents or you call children at your center?
They came with
under your
parents.
Supervision.
They came with parents.
Nee.
At the weekend only. We opened the OPD for them at Sunday also.
Oh.
So they were not disturbed in their studies. We did on Saturday and Sunday. And it's only 30 minutes per day. And
they have to come to your center, no?
Yeah, they need to come to our center.
We can train parents for home therapy?
Yeah, we can do that, but it's very costly. It's 3.5 lakhs, so parents cannot, all the parents cannot afford it.
So compliance is 100%?
No, sir. 80 was the sample size and 65 finally came.
So it's 9:25 now, and we'll finish on time. Thank you very much for your
Thank you, sir.
presentation, sir.
Thank
Excellent
you.
presentation. Thank you so much.
Please come all the